Hello, I am now narrating my PowerPoint presentation. I don't love doing this. I'm not good at it. I'm going to try to do it all in one take. I'm going to try not to go off on tangents. I'm also not any kind of content creator, so I don't have a great microphone that's going to filter. You're going to hear all kinds of things, like maybe birds at my bird feeder. It looks like there's a storm coming in. You'll probably hear wind and all kinds of crazy things. So bear with me. So I'm going to get started. Oh, and also if you love people stumbling over words and saying a lot, you're going to really love this presentation. So I'm going to get started. The title, Compulsive Exercise and the Prevalence of Eating Disorders in Men by Eva Ingram for the Chicago School. This is the presentation for our Substances and Addictions class. What this presentation is going to cover is basic definitions about eating disorders and the history of eating disorders. I'm also going to go over some definitions of things like diagnostic tools, and then finally we'll have a case study and treatment planning for that case study. So I hope you enjoy this. So here's the history of eating disorders. They were first recognized in the 12th century. These mainly had some religious overtones to them. That's still present in some religions today, like with Lent or Ramadan. And it was a way to purify yourself. It was a tool to be more spiritually closer to God. The term anorexia nervosa was first recognized in 1873. And it took all the way till almost 100 years, 1978, for traits, personality traits, and some sort of pathology to be applied to the term of anorexia nervosa. So things like body dissatisfaction, perfectionism, and the ritualism behind the eating disorder. Following that, in 1979, that is when bulimia nervosa was recognized as an eating disorder, compensatory eating disorder. Eating disorders first entered the DSM. It was the DSM-3 in 1980. And 2013, the DSM-5 expanded the categories of eating disorders, including unspecified feeding and eating disorders, or USFED, which is what the topic will be sort of placed in that we're talking about today, which is compulsive exercise. And in 2022, the DSM manual removed things, descriptors like weight and amenorrhea to reduce gender bias in diagnosis. That's about all they did to update it, but we'll get into that. So here's the pathology of compulsive exercise. Compulsive exercise is characterized by an uncontrolled urge to exercise despite illness, injury, or emotional and social harms. There's higher levels of anxiety, guilt, or irritability when unable to exercise. There's strict adherence to exercise routines with an inability to adjust regardless of athletic goals or effectiveness, also known as exercise rigidity. It's compensatory behavior. In other words, you're doing it because you ate food. So it will be compensatory behavior for calorie consumption. In other words, used to burn off food or get rid of food, purge yourself of food. There's a lack of exercise enjoyment, meaning seeing exercise as a chore. They don't enjoy exercise like people who normally go to the gym. Strong associations with perfectionism, low self-esteem, depression, and social anxiety. There's an intense focus on idealized body types, and you'll see that come up again and again as we go into talking about things like social media influence. And there's high comorbidities with body dysmorphia, binge eating, and calorie restrictive eating styles. So, eating disorders, male specific behaviors. So, how eating disorders manifest in males, obviously very different from females. And this is something, if you're watching this presentation, would like to comment about. Why do you think that is? Why do you think that there is a de-emphasization in gender-specific behaviors and attitudes in diagnosis and research currently for mental health disorders? Okay, so it says male eating disorders often manifest in different ways from the more widely recognized patterns seen in women. While women may focus on thinness, men are more likely to strive for a more muscular physique. So this can be also described as size morphia, muscle morphia. So there's an obsession with gaining muscle or bulking up, severe restriction of certain foods under the guise of health or performance. So these would be, sort of an orthorexia, kind of only eating organic foods or severely cutting carbs or only eating a lot of high amounts of protein. There'll be compulsive exercise routines, extreme focus on weight, shape, or body composition. Again, not really emphasizing thinness, but maybe leanness. So more visible muscle, more vascularity. Those are the types of focuses that males will have. Stigmas surrounding males with eating disorders, and we'll go into that a little bit further, and use of muscle enhancing substances. So, and that's another thing we'll kind of expound upon later, but often these extreme exercise routines have a catabolic effect, meaning they will decrease muscle instead of add muscle. So then they have to artificially add muscle to get the look that they want. So it's kind of like a cyclical pattern that you'll often see with eating disorders. So, addiction and obsessions. So there's a fine line between addictions and obsessions, and compulsive exercise would be classified more as as obsessive behavior. Obsessions come from the attempt to control anxiety brought on by a belief of combating negative consequences. Addictive behaviors have a physical craving mechanism and regardless of consequences. Addictions have escapist and pleasurable properties, while individuals with obsessions do not enjoy the acts they are performing. That's the compulsive part. They have to do them. They don't want to do them, but they feel as though they have to. Individuals are motivated by the compulsion to exercise. The rituals and rules applied to exercising must be completed, regardless if the exercise has any notable effect. And again, so an example of this in compulsive exercise would be something like doing 200 sit-ups. There's no evidence doing 200 sit-ups is going to give you visible abs or six-pack abs at all, but in their belief system, that is what must happen to complete exercise, and complete exercise in the way that they feel exercise needs to be completed. So we're going to go with gender biases in research. So there is a lot of bias in research with male eating disorders, which can make the diagnosis and the treatment a little more difficult. So the first thing is the assumption that eating disorders primarily affect women causes researchers to overlook the high prevalence in men. So if you look at some research journals, it'll say only maybe 2% of males will have eating disorders, whereas more current journals have placed it at 30%. If you take into account something like binge eating disorder, it could be equal or potentially higher than diagnosed in women. Feminized diagnostic criteria. So diagnostic tools and assessment tools historically focused on behaviors typical of women, such as vomiting, laxative use, while failing to adequately address male typical symptoms like purging without binging, steroid use, or excessive exercising. So again, if you look at journals that focus on compulsive exercise, probably if those journals were written prior to 2019 in some post, even the research subjects will be primarily women. So there are huge gaps in research when it comes to men. So, misinterpretation of symptoms. Clinical tools may fail to distinguish between healthy athletic pursuits and disordered eating behaviors, often overlooking symptoms entirely, leading to a false sense of prevalence. So, yes, again, there might be some behaviors that, say, male athletes do. And they only, and this would include something like bodybuilding, if you want to include that as a sport, where they do these extreme behaviors, but they do them maybe for competition, or if they're playing a sport or something, and then when they're not doing these things, they do not have these behaviors. So it would not be considered disordered because they can control it, they understand why they're doing it for a specific purpose, and everything is designed to get to that purpose, which would be kind of the difference. Underreporting and stigma. There's a double stigma that exists where men feel shame for having a female disease, leading to lower disclosure rates and limited sample sizes for research. And delayed diagnosis and treatment gaps. We go back. Oh, it won't let me. Okay, so expounding on the previous slide, what is happening within research is that being that the focus is so female oriented, again, it's limiting research, it's limiting really being able to pinpoint some of these behaviors, and what tends to be happening is the disorders themselves tend to get feminized, and while I don't want to go off on too much of a tangent of it, when you do hear about men in some of these studies, they will generally only refer to same-sex attracted biological men, again, kind of with the misogynist look at these disorders as something that really only women do or very, very feminine men do, which, again, we know all gay men are not very feminine. We know all, behaviors aren't as monolithic as sometimes some of these studies try to portray them. And it also prevents barriers to treatment, so deficient knowledge and skills within healthcare. If you're going to treat eating disorders, there probably should be some expanded knowledge. Most clinicians do not have that. Credentialing, I think, is very important in this instance, and as well as continuing education as we learn more about these disorders. Biases as to what eating disorders look like. So again, in most people's mind, an eating disorder would be anorexia nervosa. You would see muscle wasting, thinness, extreme thinness. A lot of eating disorders do not look like that. Even with women in bulimia, like classic bulimia, the vomiting and purging of food, they can be bodies can be what's considered overweight. They can be normal size. They can be bigger. It's not all about thinness. And with men, again, because the focus generally isn't on thinness, people who have that bias, clinicians who have that bias, may not take their distress as seriously. Again, believing that disorders are female exclusive. I kind of already covered the homophobia and the misogyny of ascribing disorders, male or female characteristics, or maybe only gay men will do it because they're kind of female. And access to comprehensive and specified care. So it's very hard to find someone that specifically works with males in eating disorders, because again, there is that belief that there are it's mostly females, and men have lower help-seeking behaviors. And if they're a male and they have something that they feel is kind of like a female disease, that will add more stigma to their seeking help, and that's going to delay any kind of diagnosis or ability to get help. So quickly, I'm going to explain some of the diagnostic tools that um, therapists will use. So these are diagnosing eating disorders and guiding clinicians toward accurate diagnosis and helping monitor treatment progress. The diagnostic tools for compulsive exercise, so structured and unstructured interviews. The purpose of these interviews are to gather information such as physical, family, and mental health histories, as well as present mental health. Structured interviews gather standardized data to increase diagnostic precision and decrease the variability in assessments. Structured tools help quantify the level of impairment and severity of symptoms. Unstructured interviews are exploratory, open-ended questions. This allows for the development of rapport and a more comfortable environment for the patient. So you can use questionnaires. Questionnaires in mental health care act as screening tools to efficiently identify symptoms, as they are scalable and scoreable, and allowing assessment of severity and tracking progress over time, because they can be re-administered. You can give someone a test initially and then 6 months later give them that same test to see where they are in their progress. A questionnaire that specifically targets behavioral aspects of compulsive exercise is the compulsive exercise test. And of course, just simple observation. Observations allows clinicians to gauge temperament, ability while responding. And in diagnosis, it's used to, you can see behavioral patterns, nonverbal cues, emotional states that may not be, communicated verbally, but even tone of voice, or if they hesitate to answer a question, can be a big clue. It aids in confirming the diagnosis, tracking progress, but also ruling out other things like cognitive and neurological conditions, or even some physical conditions. Observation is usually occurred within clinical interviewing, and you can use them concurrently with clinical interviewing and questionnaires. So the levels of care, just quickly going over those. So when we do the diagnosis, everybody's on the same page. We have inpatient care, that's the highest level. It's a 24-hour secure, usually hospital setting for acute crisis. Live-in patient or clients have structured environments for individuals needing intensive care, long-term care, and the addition of medical management. Partial hospitalization, or PHPs, are often called day treatment. This involves 5 to 7 days a week, often 6 hours a day, providing intensive therapy while patients return to a residence or group home at night. Intensive outpatient program, and usually these are a step-down process, so if they start an inpatient, you want them to step down to these levels. Intensive outpatient program, or IOPs, are structured non-residential treatments, usually 3 to 5 days a week for 3 to 4 hours daily, focusing on coping skills and stability while allowing routines. This is where a lot of psychoeducation can come in, and getting people prepared for re-entering sort of things like the workforce, or society in general. The most common form of therapy that most people know of is outpatient therapy. It's the lowest level. Regular, often weekly or bi-weekly, individual or group therapy sessions with medication management if needed. So we have our case study, and this is Jake. He's a 29-year-old fitness enthusiast who has a passion for exercise. Jake is employed as a bank teller and has always been health conscious and leads an active lifestyle. He started going to the gym regularly in his early 20s, aiming to stay fit and maintain his health, as his family of origin has a history of cardiac disease. Over time, his workouts intensified and began spending longer hours at the gym, often sacrificing social engagements and leisure activities with family and friends. Jake reports he feels restless and anxious when able to work out, but despite the feelings of fatigue or injury, Jake pushes himself to exercise daily, believing that any deviation from his routine will lead to weight gain or muscle loss. He meticulously monitors his calorie intake, spends hours planning his workouts, exhibiting excessive compulsive tendencies. Jake Jake's workout routine has taken a toll on his personal and professional life. He frequently arrives to work late or clocks out early to prioritize his gym sessions. His relationships suffer as he offers prioritizing exercise over spending time with friends and family, and states he will worry about dating when he meets the right person who appears physically fit in his perception of physical fitness and body his idealized body type. His relentless exercise regime has led to overuse, injuries, and sleep disturbances. Despite experiencing physical pain, he ignores warnings and pushes himself, fearing the consequences of a missed workout. So we're going to take a look at his treatment plan. We're going to start with diagnosing him. So to diagnose him, it will begin with a clinical interview. This will be used to establish a rapport with the client. Open-ended questions will be used in an investigatory way to gather information, taking note of verbal and nonverbal cues. I think that's a great way to start any kind of session, mainly because you want someone to feel comfortable with you. If you need to do something like a biopsychosocial evaluation, that can be done, after there's some kind of initial rapport or maybe at the next session. His symptomology is an examination of what activities and emotional triggers that affect the client's behavior. Notable behaviors including long hours at the gym, pushing himself to exercise through illness or injury, prioritizing the gym over social interactions, and the belief that deviating his routine will cause weight gain or muscle loss. Jake is calorie conscious. He, combined with vigorous workouts, suggests compensatory behavior with food. He also exercises for an aesthetic look and prioritizes looks in others. So from the information gathered at his clinical interview, his potential diagnosis would be compulsive exercise with indicators of body dysmorphia. So again, we already kind of know that he probably suffers from this eating disorder, but to strengthen any diagnosis, it's always good to do a diagnostic assessment or cross-reference, and that would be sort of part 2 of the treatment plan. So these are some suggestions as his treatment planning, modalities and techniques. So the first thing would be suggested is psychoeducation, providing Jake with the training and nutrition coaching, providing a balanced and exercise diet routine to follow. This will help the client understand how their beliefs about exercise may be counterproductive to their goal. So again, over-exercising leads to health problems. It also takes, if his goal is muscularity, doing something like, say, a lot of running. People love doing it because it feels hard and it does burn a lot of calories, but it also burns up a lot of muscle. So if he's combining a lot of vigorous exercise with weight training, trying to improve his muscle and getting frustrated, this is part of his problem, and he kind of needs to understand a little bit better about how the human body works and how his belief system is counterproductive to his goals. So recommended therapies are cognitive behavioral therapy, and this is to, again, help identify the irrational thoughts and behaviors. Exposure and response prevention will help the client adapt to changes in their exercise routine. So when people do things like muscle building, generally they do things like either a body recomp, which is a very slow way of reducing body fat, or they do a bulk and cut phase. Those are kind of the two normal ones. Jake is used to seeing his body like X. He's trying to emulate an idealized body type. He may have to gain a little bit of weight in the short term to reach his idealized body type in a way that's sustainable, and he will probably have problems with that. So the exposure therapy will help him through that process. Acceptance and commitment therapy will reduce the client's feelings of stigma surrounding their eating disorder, body dysmorphia, and self-esteem. And that's an important component of this because it is what it is. People have their issues, and knowing that there is a diagnosis sometimes will make people feel better, but oftentimes they will have distress over that diagnosis or try to personify that diagnosis, and that's something we want to avoid. Technology. So technology will be our friend with compulsive exercise. So using technological tools such as trackers will help Jake chart his progress and track when there's instances of compulsive behavior. Using notes or a journal app will help him sort of work that out. And then it also will give the therapist a good idea about how much time he spends exercising, how much he plans exercising, how much he actually thinks about exercising still, and how much time he spends on alternate things like socializing. So if there's a disruption in getting him back to something that could be a little more regulated, everybody will be able to see it, include the therapist and also Jake at the same time, and that can be, a point of discussion in future sessions. So treatment planning, the test results, and levels of severity. So Jake would be administered a CET to evaluate his mood, levels of exercise. The CET also detects levels of exercise enjoyment, exercise rigidity, and exercise as a weight loss tool. The CET is a 24-question survey that uses a 6-point Likert scale, with 0 being never and 5 being always true. The questions are separated by category. They're total, then each category is converted to a mean score. The subscale or category scores are converted to a total mean score, and that gives you your final test. So the test caps out at 15. So anything 15 and above, you kind of don't need to score anymore. You already are at a severe case. So Jake scores high in the amounts of exercise and exercise rigidity, and using exercise as a means of weight loss. Those were all in his case study. We already know that to be true. But there's no evidence that he dislikes exercising. So he doesn't have anxiety about going to the gym. He's very preoccupied with it, but he doesn't seem to have a negative view of going. It also, the exercising doesn't seem to affect his mood. So someone with a more severe presentations of compulsive exercise would chronically be worrying about exercising. That's all they would think about. They wouldn't be able to focus on much else. And with most people, exercising kind of boosts endorphins, and they enjoy exercise. Even if they don't want to initially do it, they tend to feel good after exercising. People with compulsive exercise do not feel good. So if we were going to give Jake a score, like an actual score with this, he would probably play somewhere in the moderate category. So it can easily tip. He's probably at the higher end of moderate, but he doesn't have quite all the symptoms to give him a high score. So if you wanted to make sure, you could cross-reference with something like the DSM-5 TR. So the DSM-5 TR does not have a category of compulsive exercise all to itself. It places it into the unspecified and feeding disorders OSFED. So their levels of severity are more like mild, which would be 1 to 3 times a week, moderate 4 to 7, severe would be more than that, something like 13 episodes a week, and extreme would be 14 more days or episodes a week. So we know Jake probably goes to the gym every day, so that's at least 7 times a day. However, he doesn't go multiple times, and he doesn't exercise outside of the gym. He doesn't skip work to go to the gym. He might show up late here and there, but he doesn't take his sick days just to go to the gym, or at least there's no evidence of that. So while Jake does exercise 4 to 7 days a week, even the DSM-5-TR would probably place him at the moderate level of severity. So, treatment planning, level of care. The level of care for Jake would be at a moderate level, although he has exercised through injuries in the past. There's no evidence of any current injuries that require hospitalization or would force him to abstain from exercise altogether. So usually abstaining from exercise is not recommended, and unless he had an injury that would require stopping exercise to recover from, he would not need any kind of hospitalization. He has a demonstrated level of competency and self-efficacy as he's able to perform his job despite his disorder. So he doesn't need intensive psychoeducation on how to re-enter the workforce. He doesn't need constant monitoring. He doesn't have additional health problems that would need to be monitored with a higher level of care. So while Jake does use the gym to avoid family events and intimate relationships, his job is social. So it's with heavy customer contact and coworkers. He's a teller at a bank, so that's social. He does know how to socialize with people. He has to have some level of comfort with it to do his job. So he can do it. He's just choosing not to. So that would indicate that he doesn't need that intensive level of learning how to speak to people correctly. That would not be part of his psychoeducation or part of his therapy. So despite preferring the gym to socializing with his family, he appears to have a good relationship with them. So that may or may not be a factor in his treatment, dealing with his family. So again, that would put him at the lower level of care. The recommendation would be Jake participates in one-on-one therapy sessions once a week. He'd be encouraged to attend group therapy sessions at least once a week. And the reason why is men often see increased results in group therapy. Groups address isolation, stigma, and promotes emotional expression through peer support. Male-focused groups are highly effective, providing a safe and space to challenge stoicism and build up emotional resilience. Jake would also be encouraged to work with a training and nutrition coach to create a realistic and sustainable, reachable fitness goals and routines. And he could reach out to his readouts from his Apple Watch would help monitor episodes of exercise versus other activities to detect any lapses in treatment. Okay, so treatment planning. This is going to be the relapse prevention part. Relapse prevention planning will be a collaborative effort with Jake to help him reach his goals. So we're going to work on you would look at personal goals for self-improvement. This may include goals like spending more time socializing with others or a bigger focus on exercise recovery. We're going to identify any potential triggers or challenges. Jake will need to be cognizant of what triggers his body dissatisfaction, which then triggers his compulsive exercise, such as images from fitness influencers. So this is a big one because a lot of times people see idealized body images and not realize that they're either heavily manipulated or they think that these guys look like this all the time when they don't. So if you look at a guy who's on the cover of, like, let's say a fitness magazine, he prepared specifically for that photo shoot. He doesn't look like that all the time. Guys who do competitions do not look like that all the time. They do it for a sustained period of time, and then they stop that behavior, and then they go on to look like everybody else. So that's something that a lot of people who have body dysmorphia don't understand. And that's something that would have to be addressed in his therapy and potentially triggering any kind of lapse in treatment. Methods for coping with stress and minimizing triggers. Jake will need to decide what coping mechanisms he will use, such as peer support from his therapy group would be a great one. Reaching out to his therapist, his family, all those great support systems that we're going to help him build. Daily life and care plans. Jake will need to decide what he will use as self-care. So perhaps instead of going on intensive runs on the treadmill, he'll go for a walk on the woods instead. because it's calming, it's relaxing, it's something recommended by a lot of people because of the environment, a natural environment versus like a indoor environment all the time. Could be something he could do for self-care that's still active but yet not punishing his body. Building his support system, we kind of already went over. So it'd be his therapist, his group therapy, his family, his friends, reestablishing great connections with all of those people and maintaining them as well, because men can sometimes turn inward a lot, and so that's something we'd also want to work with him, is asking for help. Men have some trouble with that sometimes, so ask for help. Understand lapses and relapses. So this is a big one for me. So Jake needs to understand that lapses in treatment are part of the process. It's not failure. I feel like what triggers a huge relapse is there will be a lapse in something, like someone will take that drink, or someone will spend a little too long at the gym, or someone will skip a meal, and they'll think, ooh, I did that behavior, treatment didn't work, I might as well go all in. Knowing that the potential for missteps in treatment and accepting them as part of the process, and maybe even kind of expected, will not lead to a full relapse, and they need to understand that. And if it's understood they'll make mistakes, I feel it'll be less pressure to be for perfectionism, which people who have these types of eating disorders already have. They're already very, they have a very rigid sense of what perfectionism is, and any misstep might stigmatize them and make them feel like they failed when they actually didn't. It's part of the process, and that's something that can be worked through very easily. So here's my boring references. It was a long presentation. I hope you enjoyed it. If you stuck with me all the way through, thank you very much, and I look forward to hearing your comments when this gets posted on our Canvas site. Have a great week, and I look forward to viewing your presentations.